I have personally given several presentations. The first was within a symposium on biosimilars, and I think that's a very important aspect of what's going to be happening within the field of inflammatory bowel disease. I think the evolution of biosimilars is going to be inevitable, but the question is how to do it in the most appropriate and safe manner to allow the potential cost savings of biosimilars. The second opportunity I had to discuss was after the description of all of the new therapies that are coming on as the next generation that include new adhesion molecules, chemical inhibitors such as STAT inhibitors and JAK kinase inhibitors, and new cytokine inhibitors including the IL-12/23 inhibitor. I gave a summary discussion of how we might be positioning these therapies in the future. Well, the main issue right now is that pharmaceutical development has really been targeting the patients who have not responded. And this has been problematic because patients respond to therapy earlier in the disease, and the later we intervene with therapy, the more likely that the patient already has structural damage that may not be overcome. So, for instance, in Crohn's, once patients develop strictures or fistula, you can't prevent them. And it would be like treating rheumatoid arthritis when there's already joint damage. Our goal is actually to prevent gut damage. It's basically treating the right patient at the right time with the right therapeutic approach. It is everything, but the earlier the better is actually very important because, number one, the patients will respond better to early intervention, and that will allow us to prevent the complications that lead to the real morbidity in these diseases. Well, there are many differences between adults and children. First is growth and development for children, and that's something that adult gastroenterologists don't need to pay attention to. A second is the family. So treating an adult is a personal relationship between the doctor and the patient. In pediatrics, it's really between the doctor and the family. Obviously, the understanding of children, what we call self-efficacy, is different in children than in many adults, but to be honest, self-efficacy is an important aspect of the care. It turns out that much of the burden of these diseases is not necessarily the medical burden, but it's the psychosocial burden of these diseases, and that needs to be accounted for and really taken care of. It very much goes back to the details of who is the right patient at the right time, and also while many of our therapies are effective, maintaining that effectiveness is very important. A number of the drugs that we're using, including the biologics, were not originally developed for inflammatory bowel disease, and we're learning that the dose and the metabolism of these drugs is different in patients with IBD than perhaps patients with dermatologic diseases or with rheumatoid arthritis. So we need to adjust these therapies in inflammatory bowel disease differently than in other immune-mediated diseases. I think there are two aspects, and I describe it getting people on the bus and keeping them on the bus. Getting them on the bus is identifying the appropriate therapy for the individual. And then keeping them on the bus, because IBD is a marathon, it's not a sprint. And keeping the patients on the bus means keeping the drugs working in the individual patients, so they're not shifting back and forth. Maintaining remissions is really the long-term important aspect of treating inflammatory bowel disease. And that needs to incorporate both the effectiveness of therapy, but also monitoring for safety.